My name is Hunter Hernandez. I'm a third-year medical student at NYU, and I just want to thank you for the opportunity to give this talk to all of you this morning. So we have no financial disclosures or conflict of interest to report. So accurate patient selection remains a critical challenge for successful partial gland ablation treatment strategies. Experts agree that unilateral MR-visible Gleason grade 2 and 3 disease represents the ideal scenario for employing this treatment approach. However, accurate definition of lesion volume and margin, as well as the presence of invisible contralateral disease, pose challenges to the clinical implementation of this strategy. So template-based transperineal pretreatment risk stratification biopsies offer an opportunity to confirm unilateral disease and improve definition of disease volume and margin. So the goal of this study was to evaluate the role of a pretreatment transperineal planning biopsy in refining candidate selection for partial gland cryoablation. So the study design of the study, it was a retrospective review of men diagnosed with unilateral MR concordant PT1C through PT2B, Gleason grade 2 or 3 prostate cancer per transrectal diagnostic biopsy who were under consideration for partial gland cryoablation. Transperineal biopsy was performed with 5mm template sampling according to Barzell zones and targeted to biopsy to the index lesion with 4 samples. Disease volume and location were assessed and candidate failure rates were calculated. We define candidate failure as the following: either upgrade to Gleason grade group 3 or higher, identification of contralateral Gleason grade group 2 or higher, or disease within the posterior midline zone. This particular factor was chosen due to the technical challenge of achieving ablation in this anatomical region due to the presence of the urethral warming catheter during cryoablation. Logistical regressions were used to assess whether clinical factors predicted candidate failure. The clinical factors assessed included age, PSA, MRI information, and transrectal biopsy information. So 101 men met the inclusion criteria, and of those, 34 were defined as candidate failures. 3 upgraded to Gleason grade greater than 3, 18 had disease in the posterior midline zone, and 21 were found to have contralateral Gleason grade group 2 or higher disease that was not initially visible on MRI. On logistical regressions, the only 2 factors that were predictive of candidate failure were MRI lesion size, which was measured by the largest cross-sectional area, and max cancer core length. The other characteristics that we analyzed were not predictive of candidate failure. So in conclusion, candidate selection for partial gland ablation based on diagnostic biopsy and a unilateral MR lesion alone potentially risks undertreatment of 20% of contralateral Gleason grade 2 occult tumors and unwittingly treat 10% of these men with Gleason grade 4 or higher disease with partial gland ablation, a strategy that carries higher oncologic risk. More specifically to cryoablation, treatment to the posterior midline zone may be needed in approximately 20% of men selected based upon diagnostic trust and MRI alone. These findings suggest a role for further refinement of patient selection criteria, and specifically candidate failure were associated with factors associated with increased disease volume, as we talked about the increased MRI lesion size and cancer core length on transrectal biopsy. So thank you again for your time and attention, and I'm happy to answer any questions you may have.
Does anyone in the audience have any questions for the presenter?
That was great work, thank you. There's a quick clarifying question. So they
Sure.
had initial transrectal biopsies, and then this was comparing to a transperineal. So they had both?
Correct, yeah. The transrectal was diagnostic and transperineal was pre-treatment planning.
Yeah, so with the cryoablation strategy, and Hunter, great job presenting the data. One of the challenges with the urethral warming catheter in the cryoablation patients is we don't actually, with a margin consideration, just behind the urethra, we don't transrectally typically biopsy that region because you pass right through the urethra. That remains at NYU our primary diagnostic strategy to do transrectal MRI ultrasound fusion biopsies. So as I was beginning my cryo experience, I started to wonder, as we incorporate these centimeter margins, how often am I missing disease behind the urethra that I would then shelter from the cryoablation effect? So that was one of the reasons we selected that as a candidacy failure. And it is an interesting concept here. That does not strictly fail them from a cryoablation pattern, but it's good to know that you can adjust your treatment accordingly by including more ice behind the urethra, or even in select cases potentially not using the warming catheter. But having that understanding that 18 of the cohort did have that disease location, it does adjust your treatment strategy. You could then use it as a justification that you are a candidate failure, but not necessarily, more of a technique refinement.
So a comment and a question.
Sure.
The comment is we published a study looking at the histological appearance after transrectal ultrasound on the radical prostatectomy series. This was with Professor Manish Patel, and the histological anatomical location in transperineal. We did a head-to-head study, and they're very different areas that are found with the two different techniques. That's the comment. The question for you is a different question. Let's say the initial biopsy was, in your view, inadequate. What would you define as inadequate? Is it having a transrectal biopsy or a certain inadequate number of cores? What would you call inadequate from the findings that you had in the initial biopsy? Because we often get people referred to us who have 12 cores, even transperineally. And so is that inadequate? Are certain areas inadequate from your experience? So what's inadequate?
Yeah, specifically, I can refer some of this to Dr. Wysock as the physician. But in regards to the study, these patients, the transrectal wasn't, if we included in the study, the transrectal wasn't inadequate because the transrectal implied that they were ideal candidates for focal ablation. And that's why we went forward with the transperineal. But I can refer to Dr. Wysock to continue.
Thanks, Professor Trigger. That's a great question. It's not so much the inadequacy, and you are correct. I get patient referrals who've had a standard of care biopsy, and before I'm ready to take them into a partial gland treatment pathway, often I have some reservations as to the accuracy of the biopsy. As we know, there's a lot of inaccuracies in MRI reads, there's a lot of inaccuracies in targeted biopsy. A 12-core plus a targeted biopsy remains our standard and our accepted standard for patient selection. What I worry about and what I've seen in early data is that occult contralateral grade 2 disease, and that's an early candidate failure. What we see here is that's about a 20% rate. That is the same as what whole gland evaluations of candidates would be, and I think it mimics a lot of what we saw from your PSMA work as well. And so it is an interesting idea that if you identify those patients earlier, you can then risk stratify and maybe change treatment strategies, or at least expectations, which we've talked about in these study designs, because that second ablation may be down the line. And as we move towards, and I've said this to a number of people over the weekend, a partial gland sparing approach for prostate cancer, we will have to accept that there's going to be a secondary tumor that develops in the untreated gland at a certain rate. Knowing early which patients are going to be more prone for that changes our strategies for follow-up, et cetera. It doesn't necessarily invalidate the paradigm. But this paradigm of looking for the secondary tumor is present in so many other oncologic approaches that are already embracing, or by necessity or their science, an organ-sparing approach: breast, lung, colon, et cetera. We could go on and on. So that's part of what this is. It's not really an inadequacy of the selection criteria that we use. So I don't see that a 12-core plus 4 biopsies or targeted biopsies that confirm your index lesion and your unilateral disease is inadequate. I wouldn't say that in so much. What I really have sought to do with this as we roll out cryoablation or any partial gland ablation strategy is we're trying to protect the data and make it as robust as possible, because this is a new paradigm that we're taking on. There are a lot of criticisms, there are a lot of critics. So this was one way to sort of safeguard as best as I can the selection for these patients in our early data.
Perhaps a question for Dr. Wysock, sorry. But it seems that the process is different in the States to what I'm used to in the UK, where patients are coming in with transrectal biopsies without an MRI. Is that correct?
Yeah.
Yeah, so then you will be performing an MRI when they come to NYU.
Correct.
And then deciding to do a transperineal biopsy off the back of that.
Right.
So were there any instances on the MRI where there was clearly a contralateral lesion, PIRADS5, that wasn't necessarily represented in the transrectal biopsy? And if so, how did you deal with those?
Yeah, I might have to refer that part to Dr. Wysock.
Yeah, absolutely. If you receive a referral without an MRI, they could be undergraded, understaged. That 100%. So if we get the MRI to assess them, say they're seeking out candidacy or management for prostate cancer, and find that they have contralateral disease that their initial diagnostic biopsy didn't pick up, it could be because it's anterior or whatnot. If it's a PIRADS 5 that we find and it looks something that's completely opposite, they may not enter into this data set because they're not being selected for partial gland ablation at that point. So often, though, it is unilateral, it is confirmed. What I see more commonly is a change in the PIRADS scores. And it does prompt me to then reassess.